Musiega to start off by telling us what's all this social health insurance about, and how does it differ from other health insurances? We as a country on the 20th of October had the Social Health Insurance Act enacted as a country. The Minister for Health operationalized this act through a Gazette notice on the 22nd of November, 2023. On the 27th of November, Justice Chacha of the High Court suspended the planned implementation of this act till the 7th of February, 2023. So as we will be discussing this topic, we will not be discussing the court-related issues. We will be focusing on educating the people on what this act entails, what is in there, and what does it mean for us as Kenyans in the different realms of stakeholders in the country. So Dr. Anita, over to you to give us a brief on the introduction on what social health insurance is about, and what is it that we as Kenyans should be thinking of when we listen to the social health insurance discussions across the media. Over to you. Dr. Anita, are you connected? Okay, I'm seeing she's having some troubles connecting through. Then I think then I'll throw this question over to Dr. Abdi Mohammed, the chair of Kenya Association of Private Hospitals. What is social health insurance all about? And what does that mean for the different stakeholders as providers, as doctors, as healthcare providers, as the community members, and also as citizens of this country? Over to you.
Thank you very much, Dr. Walter. As you have introduced, my name is Dr. Abdi. I think generally, if we think about on how we can finance healthcare, social health insurance is one of the possible organizational mechanism for raising and pooling funds to finance health services. So this is one of the ways you are able to finance your healthcare system. The other being out of pocket, where individuals pay at the point of service delivery. And then you have tax-based, where government collects tax and allocates tax and uses that tax to pay for healthcare services. Social health insurance, in my opinion, seems to be the fairest of it all, if you think about it. And the objective is to improve the health and reduce the health inequalities. The second objective is being responsive to people's expectation. And thirdly, it is the only way you can ensure fairness in financing, so that you have fairness and equity in terms of financing, and fairness in access as well. That is my basic understanding of the social health insurance.
All right, thanks very much for that brief introduction. And probably as I push it forward, Dr. Abdi, I think just post independence of this country, we've had the National Health Insurance Fund carrying out these functions as you have described them. And we have recently enacted an act to more or less repeal the National Health Insurance Fund for the Social Health Insurance Fund. What is different about this social health insurance fund as opposed to what we currently have as the National Health Insurance Fund?
There are a few major differences, I would say. But if we go back a little bit, you will realize that the National Health Insurance Fund was statutory deduction compulsory for employed people. So that meant that everyone who was working formally used to be deducted. So in that sense, on that end, I think I would say we almost achieved universal health coverage. But unfortunately, if you look at our population, the people who are in formal employment happen to be around 15% to 20% at the higher end. So it means it was only mainly focused or catering for people who are formally employed. And that is what used to happen with NHIF. Prior to 2015, the collection or the rate, the premiums was from 30 shilling to 350 shilling, if I'm not wrong. That's what people used to contribute in the formal sector. In the informal sector, which was now not compulsory, but voluntary, the contribution was at 150 shilling. But sometime in 2015, 2016 is when there was a change in the contribution. There was an increase. So at that time, when it was 30 shilling and 350 shilling, NHIF, basically, in my opinion, used to pay only for bed rebates in hospitals. But it used to do a lot of other things, which was building parking lots, buying land, things which were not related to health in any way. But during the introduction of the increment in the premium, which was from 30 shilling to 150 as the minimum, and 1,700 as the maximum for the formally employed, there was some sort of improvement in terms of what are the benefit package, or what is it that NHIF will be able to cover because of the increase in the premium. So there is when we have seen additional benefits like outpatient, which was through capitation. For inpatient, we have seen surgical services being covered. Then for chronic conditions, we have seen dialysis being covered and cancer. So there was some sort of improvement. But with this current new law, so the idea is now to focus on how do you now equalize and create, remove inequalities. So this new law is trying to equalize and create equity by making it compulsory for everyone. So I know that the question that will arise is, but there are people who can't afford. It's covered in the law that those who can't afford, indigents, vulnerable, those are the people who will also be paid for by the government. But anyone else, whether you are formally employed or informally employed, must contribute. And that helps in increasing the pool in terms of the life cycle of the individuals. So you have from the youngest to the oldest being part of it. And it also helps in spreading the risk also in terms of finance and in terms of health of the individuals, so that you don't have people with extreme conditions only joining the fund. I think that for me is the main difference in terms of who is the main target for this new health insurance, for this new SHI. And I would say it's more of the informal who are left out in the previous schemes.
All right. Thanks for bringing that up. And Dr. Davji, as you listen to Dr. Abdi give this further description of what the difference is between what we are looking at in the Social Health Insurance Act as opposed to what we have in the National Health Insurance Fund, what do you see as the overall implications of this act when it comes to healthcare service delivery across the country, if the act will be implemented as it is?
I think some history that Abdi has given that I concur with, particularly on the start of this particular National Health Insurance Fund, because it was started in 1966 by the Act of Parliament and then repealed in 1988. In 1966, it was just a department within the Ministry of Health with a focus to only cover the civil servants. It is in 1988 that it was then repealed and opened up for all the Kenyans. And therefore, I must just correct this, that it was not only meant for, it has not only been for the employed, that is National Hospital Insurance Fund. National Hospital Fund is for everybody who was contributing. We have those who are in the industry or informal sector. We have everybody who is not employed, like our grandparents, who still contribute to the same. So I don't think the Social Health Insurance Act in any way is bringing anything different with what was the National Hospital Insurance Fund. But what has come that is different from NHIF that we now see in Social Health Insurance Act are two things that are clearly glaring. Because we know that in 2011, the Ministry of Public Works and the Ministry of Health and the public sector realized that because they were the parent institution for these health care and for the public, they made the public sector workers to relinquish their medical cover, and therefore gave them a comprehensive cover, which was M+3. But then in 2014, when they realized that there was a lot of funds that were remaining, then they introduced M+6. And that was the enhanced component of this National Hospital Insurance Fund that has been in existence, that now will not be there with this Social Health Insurance Act. The other thing that has come with the Social Health Insurance Act is the two-pronged draconian precondition that you must be fully compliant with your payments before you seek any public services. That is that's in section 26(5) of this particular act. It says that you must fully be paid up and fully in the compliance for you to get any services in the public, which means the counties or in the national. And that was not there in the National Hospital Insurance Fund. The other thing that they've also put in section 27(4) is that you may not get any medical services in any of the institutions if you're not a complied member or paid up in this. And then they've gone further in section 5 of section 27(5) to say that if you are not able to pay, then they can also give you loans. So that precondition aspect that is forceful, that ensures that everybody must be able to be paid up before you get both the services in public or private hospital, wherever, is what is now very much different with what is there in National Hospital Insurance Fund. But this idea of being membership, I mean, the very big number of the informal sectors that are part of who are part of NHIF, and I think now the forceful condition, now that which makes it non-voluntary, is what has been brought up in this particular Social Health Insurance Act. Over to you.
Thanks for that description. I see as I progress with the discussions, I see Dr. Anita Musiega has joined. Welcome to the discussions that we're having. Before I ask Dr. Anita to with a follow-on question, Dr. Abdi, do you want to respond, or Anita, do I also let you speak on to the conversation as it's moving along before I move on to my next question?
I can respond to one thing. So I listened to Davji, and I'm hearing that he's saying this new social health insurance is compulsory for everyone, even the informal. So that's what he needs to understand, that that's the main difference, that the previous NHIF for the informal sector was voluntary. So it meant that you pay when you need, whether you're in Juakali or whether you're self-employed, you pay it when you need it. And that risks or creates unsustainability. If you look at the fund currently as it is, people only pay when they are sick, when they need certain services, like they need an operation, they pay 500 shilling, then they claim 500,000 for the surgery. Someone else is diagnosed with kidney disease, then they pay 6,000 shilling, they claim 1.1 million for dialysis for a whole year. So that creates something called adverse selection, and it's not sustainable. So the utilization rate for the informal sector is around 265 to 300%. So meaning every shilling NHIF collects from the informal sector based on voluntary contribution, they pay out 3 shilling. And we all know NHIF as it is dependent on member contribution. So that is impossible. It's like trying to live beyond your means. So what is the new thinking is everyone, irrespective of how little they will contribute, which the minimum has been said to be 300 shilling, must contribute. And that creates a bigger pool, which is sustainable, which is equitable, and which gives access to everyone. But there are two other funds which current NHIF does not have. One is the primary healthcare fund, which is tax funded, paid for by government, which gives you access to preventive and curative at the primary healthcare level. So that hasn't been there. There is also a second fund, which has been one of the biggest problems that we have had over the last few years since the new constitution came into force, the issue of emergency care. If you have been a provider or you have been living in this country, we all know what has been going on, where you rush every emergency patient to the nearest public facility because you know it will not be possible to get that services at the private facility because of the cost involved and because of the unavailability or because of who takes care of that bill when the patient is being treated. So this new social health insurance has created that fund, which now allows patients to be given the services from any facility which is nearby without having to move all along to other areas. Then there is the chronic fund. If you know very well what's happening currently, because of the limit in terms of what NHIF collects, they can only give so much benefit beyond which they can't. That's why you have limitations on how many radiotherapy, how many chemotherapy you are entitled to as a family or to as a contributor or a beneficiary. But we all know it's not adequate as it is. So what has been happening is two things. People who have money will pay the extra chemo or radio that they need once they exhaust their NHIF. But what happens to the other group, the middle income guys? What happens is they start selling things, their houses, their shamba, their cars, their assets, basically, borrow even some to try and continue with the treatment. Then there is also the untouchables, the civil servants. So those ones, I don't think they even have a limit. So they will continue with the benefit as required. But there is the other group, the poor. What happens? That is the end of treatment for them. So the disease becomes rebounds, and you have now more complications because you have been treated halfway, and the other half hasn't been done. Now you are even worse off than where you were at the beginning. So those kind of people now will not have to worry where does their benefit end, because there is a chronic fund that will be able to pay for them, and that was not there before. So in insurance terms, these are called excess loss. So where you have your benefits, you have exhausted, and now you move to the chronic fund and the critical illness, ICU care, NICU. Those were not things that were given to people who contributed, whether you were formally employed or informally contributing. These benefits, critical care, was only accessible to the civil servants or people who had enhanced schemes.
Thanks. I want to cut you off a bit so that I can also just open up the discussion a bit. Let me first welcome Honorable Jaldesa, who is a member of the Health Committee at the Parliament of Kenya. And I think I want to advance this next point and get to hear your views. Welcome, welcome to the panel. This bill and when the bill was brought to the floor of the House, it was a ministry-sponsored bill, and Parliament was involved in reviewing this bill before it was passed on as an act. What would you say was the role of specifically your committee, and what were the things that you saw in the act that would be beneficial to Kenyan as it's implemented across the country? Over to you, Mheshimiwa.
Thank you. And thank you for inviting me for this. Bill is sponsored by the Ministry of Health, and that it was brought to us because it must come to Parliament through our committee, because it cannot come without us approving it. So initially, when we looked at the bill, it had lots of things which looks unpalatable, like the CEO of the organization must be a medical, an advocate of High Court, which of course there's no justification, and that the role of Kenya Medical Association was kind of diluted to look like any medical professionals can sit and agree and say who is going to represent them. We sorted out some of these things. The bill as it is may look like something good, but the major problem is we have not understood initially why we were changing from the current NHIF to this. And the other component that you need to have known is that the CEO of the organization is one, the board is one, yet there are three funds: the primary health care fund, the social health insurance fund, and the chronic and emergency or critical care disease fund. These are all managed by one umbrella, the same CEO, the same board, but probably just like a different departments within. What is the idea? The idea is to see that everybody in this country, irrespective of their socioeconomic standard, has a medical care. That happens in many countries in the world. And if that was the idea, then the idea is good. But the practical element, the implementation of the same, will be the elephant in the room. Since the government has committed to for universal health care, where I hope the members understand the universal health care means that everybody in this country has, that's what it means. We have seen other countries which are doing the same thing. The UK is doing the same, everyone. So long as you're a British citizen, then you have medical insurance cover. You had gone to Thailand, and many other countries in the world have this. This idea, the concept is not new in this country. If for those who are old enough, around 2004, Ngilu came up with the same concept, but she came with it before it was properly developed, and it died. Even these people of ours, the current system, we have thought of these things and says we want to run with it, which is a good idea. I have no problem with anybody. A major problem. When you looked at what's the difference between this and what was happening at NHI, Abdi, the speaker was speaking before me, and others are advocating for claims management outside the insurance fund. They want the insurance fund to give the claims management to some external entities. That's actually the major contention between the health committee and the government side. Because for us, the social health insurance fund should be able to, or authority should be able to manage its own claims. But there's if you want to do business with the authority and offering claims to some other people outside, because we know that the NHIF has enough staff personnel to look after those things. The concept of giving people health cover is absolutely a noble idea. But the problem with us in Kenya is there is the component of people wanting to do business, trade with organizations, with government form bodies. And that is the only thing that we consider as inappropriate. But making health service available to everybody, every citizen, It's a noble idea, and I don't think that way anybody is opposed to it. I don't know that I've answered your questions.
No, you actually have, and you've given quite a bit of insight as to what you as a health committee were grappling with when you are reviewing this act. Probably I'll ask Dr. Anita Musiega before I come back to you. I see you're itching to speak. When you look at what is being discussed in terms of the principles and the background of social health insurance, what do you see were picked up very well in the current act, and what areas do you see are areas that we should think of improving as we move along down the road with this act?
This question is
Thank you
directed
very
to
much. To me,
Dr. Jadesa, I was directing it to
Honorable
Musiega.
Jadesa, to me.
Yes.
Thanks very much, Dr. Peter, for the question, and for the rest of the panelists for your contributions. Many apologies, I wasn't able to join in good time, but I'm here now. And to me, I think one aspect that the government has gotten right in terms of the social health insurance is the mandatory aspect and the universal approach. I mean, from our past experience with NHIF only covered about 20% of Kenyans, leaving 80% of Kenyans out of the insurance coverage, which means then the approach that the government is taking in terms of universality then means that it means that each and every Kenyan will be able to be covered within the social health insurance. And of course, there's a lot of wins in terms of looking at the chronic care and the emergency care package, and an increased focus on primary health care, which was lacking in the past because NHIF was conceptualized previously, it was leaning towards a hospital package rather than also focusing on other primary healthcare interventions. And primary healthcare interventions have been shown to be more cost effective. However, where we lose it first is the contributory nature of the SHI. So SHI is pegged on contributions, mainly contributions from employees and contributions from the informal sector. And a small part of it then is for the government then to pay for those people who are not able to contribute. So the challenge with that is that the path to UHC is a path to ensuring that everyone has access to health. But then when you decide to peg healthcare access to whether or not Anita is employed, then that poses a challenge, because what happens when Anita is jobless next month? And we've seen this from countries which have been able to use SHI as a platform for health. For example, Rwanda and for example, Ghana, most of the funding towards the SHI don't actually come from contributions. For example, from Ghana, 2.5% is from VAT. 2.5% of VAT is taken towards the SHI, and another 2.5% from an equivalent of NSSF. So whatever funds are collected from like an equivalent of NSSF to go towards social insurance for the workers, then goes to their social health insurance, and less than 10% is from contributions. And equally in Rwanda, it's a community-based health insurance approach. So now when the government pegs most of the funding from contributions from people, then that poses a big challenge in terms of reaching out to the informal sector, who have proven very hard to reach to even in other settings, and Kenya is majorly an informal sector. So yeah, for me, that's the biggest challenge. Thanks, and over.
Thanks very much for those additional points that you put up. Davji, I come over to you. As I say, you look like you've been itching with some rebates, and but
Yes.
as also you give those rebates to probably the discussion that's going on. When you look at the there have been comments on the principles of social health insurance and how this act also moves from having managed schemes to just one scheme cutting across the beneficiaries within the country. I know you have been very very active on that point. How do you see this potentially impacting other health workers, other civil servants, and other beneficiaries of the enhanced schemes? And probably just to move that forward, what do you recommend? Because we already have an act that has been passed. So over to you.
Yeah, thank you. And before I answer you, based on the presentation that was delivered by Abdi Mohammed, he came out like this Social Health Insurance Act actually provides a comprehensive medical cover that has no limits in terms of the fund system that is the existence in it. And that's what was boggling me. And that is because in the transitional section, section 5 of it says that at the appointed time, this act will not provide comprehensive or enhanced benefits. That means that there's limits to which care that it can give. And that also brings us back to this concept of the 3 different funds that we've really looked at in different way. And I think it's also basis of so many other litigation. Why am I saying this? Because this fund is said to be three-pronged. That's one is the primary healthcare fund. And this primary healthcare fund, they have social health insurance fund, and then we have the chronic emergency and critical care fund. All these funds are based on claim. That means you have to claim them from the social health authority through the claim system that they'll actually outsource. So what does that mean? It means that for the primary healthcare fund, which is actually a taxpayer's fund, that ideally, as per the Act and the Constitution, need to support level 1 to 2 and 3 facilities, because it's more of a screening, it's more of a preventive, it's more providing services within those levels. It ideally ought to be an anti-fund rather than a fund that is based on claim. Because therefore, if you put it just to be claimed, how will it help in level 3 facilities or level 2 or level 1s that are dispensary based, that are out of stock, are not stocked compared to those that are in the private sector? That's one thing. Number 2, when you look at the chronic emergency and critical care funds, it's quite explicit in the Act that you will only access these funds after exhausting or depleting your social health insurance fund. We know that these funds are meant for pooling effect. So if it is a social insurance fund that is pooled, then how do you deplete it? We are depleting it because of the tariff aspect that has been put in this Act. And ideally, we need to have it unlimited. So that's the concern we are looking at here. So therefore, the chronic emergency and critical care fund need to be based on existence. They should not be based on the depletion of this social health fund. Adding to that, I must bring something that Anita has brought, but bring it more clearly, that it's better to have these funds as a compulsory contribution. We have a situation here whereby this act in itself may be an impediment to access to care to so many Kenyans. Why? Because if you cannot afford to contribute, or if you lose your job, and in this case, I'm not talking about other Kenyans, I'm talking about ourselves, because we are Kenyans, and we have seen situations where government just dismisses you from work without any notice, and it takes 40 months to 60 months to actually reclaim your job. In this point, you will actually default in your subscriptions or in your payments. And the Act is very clear. You won't even be able to access marriage certificates. You won't be able to access land title deeds. You cannot access any public services if you do not actually be able to pay that. That is quite clear. And we find that if that goes in that direction, and even it goes to that section I said earlier, that you can't even access emergency services in the hospitals, because in accessing these emergency services, you must be able to subscribe. So that brings the concept that if we look at it only to be the contributory aspect without giving focus to the taxpayers' money that also is the exchequer funds on the side, then many people who are not able to contribute or who are disadvantaged will not be able to access care as expected. Coming to your point of comprehensive package or managed services, I must say from that point that we believe that this particular act is more of vendor driven. And why am I saying this? Because in 2020, we had, the aspect of managed schemes came into existence in NHIF in 2011, when the government made the public sector or the civil servant to relinquish the medical allowance so that they can have this comprehensive package. We saw in 2018, after the teachers went to the Medical Administrators Kenya Limited, that 2 years after that, the Insurance Regulatory Authority gave a directive that NHIF should not manage commercial services. This was almost 10 years later. I think specifically it was on 10th of February 2020. It was out of uproar that the insurance company, that the IR allowed NHIF to offer these services. We now saw that when this bill was in Parliament, there were contributions from almost 29 stakeholders, of which I have 15 of them that gave a justification why the managed services that is pooled within the NHIF was allowing access to care to many of the civil servants and their families. That's almost 6 million. And why am I saying this? Because you will access any hospital near you as long as it's able to offer you the quality of care, be it private, be it faith-based, be it public. We are seeing these removed in this particular act within the health committee. And therefore, the current act does not provide for enhanced packages for the civil servants or for the publics who work in the counties. We have a scenario whereby 373 of the public institutions that were otherwise subscribing to NHIF now are being told to get the private insurance to cover them. What then it means that all the private insurance companies are going to be given funds to a tune of 80 billion from the government coffers, because we have the teachers giving 17 billion, we have the police 10 billion, we have the counties, about 22 counties, and the parastatals. So it's a total of 80 billion that were initially pulling effect in NHIF, now going to private insurance companies. So in a way, we were seeing that it's actually geared towards these private insurance companies to get this business. That's one point. The other point that I must agree with Mheshimiwa strongly is the aspect of contracting, the outsourcing for claims management. If you look at the Act, it brings out that for the regulations, for the claims, is to actually be done by only the minister or the principal or the cabinet secretary. And then it does not say in consultation with the board as per the other acts. Then it also brings it out clearly that this claims management is the one who will determine whatever you're prescribed to. And initially in the bill, it was saying it shall be outsourced. But now it says it may be, with a prospect that 15%, again, of the funds, 15 to 20% of the funds in this Social Health Insurance Act, or 15% of the claims will be going to these private insurance bodies that are managing these funds. So in essence, as I said earlier, it's more of a privatization of NHIF or more of a vendor-driven venture in the way it is. And that's why we have created business for this private insurance company, and we are making it for it to be managed by the private insurance companies. Over to you.
A lot for those additional points that you have made. I have Dr. Mwai and Dr. Thuranera as additional panelists as we have been moving along this discussion, because I also want their voice in this discussion. And probably Dr. Mwai, as you hear the discussions going on, and I've seen a couple of questions on the charts relating to the spirit of the three funds. So probably just give a quick highlight on as to what was the a quick recap on what was the spirit of these funds. And as you hear the questions, how do you move from one fund to the other across the different levels of care? Because you hear questions on one is depleted, then another one checks in. So when does one move along the different levels of care from one level of, from one fund to the other? And what's the overall principle of these funds? I'll probably move that question to you first, before I get on to the additional questions that are coming up from the discussion. So over to you, and welcome, Dr. Mwai.
Thank you very much, Chair. And just in a quick review, I think I've been listening. Sometimes it's good to listen than to talk. But I want to highlight some few critical things that are important to understand. One is that social health insurance is designed in principle to take care of all Kenyans, regardless of whether you are employed or non-employed, payroll or non-payroll. And in this concern, then, we find social health insurance that have been built ideally in the legacy time, grounded on the principles of covering for the employed people. And that is why every time you realize the discussion of social health insurance starts, people quickly, move that discussion to employed people carrying the burden. So the key thing that you realize with the new system is largely driven by all Kenyans, regardless of whether you are employed. Actually, being employed is an extra advantage for you because you have an employer who can enhance for you the benefits. However, that enhancement cannot be put into the social health authority or insurance, because every time you put that benefit, you advantage a certain population inside the social health insurance, which is against the principles of equity. Now, having said that, I think if you have looked at the bills are interrelated in principle. And the first thing is that there is the community health care level, which is ideally funded by government, which is tax-based. And in that, then you have the community healthcare promoters who are supposed to drive the prevention agenda, and also linking households into the healthcare system through the digital ecosystem that is being rolled out, as you might have seen within the digital health bill. Now, the first then pool becomes a primary healthcare pool, and this primary healthcare pool is not paid for, is non-contributory, because it's ideally driven by the social health insurance. It's driven by the government prepayment into the pool, and therefore every Kenyan will be able to access this primary healthcare fund, and it will assist us push the social health protection from the higher level facilities to lower level facilities, so that level 2, 3 are able to also have a place they can bill for the services they provide in what is largely an output-based kind of financing. And that is why there is another bill, which is the FIF bill, and that is to make sure that the public facilities are, enabled to also retain the funds that they get from service charge, so that our clinical providers, our doctors, and others have money at facility level to be able to improve services at that level, as it used to happen before devolution. Now, of course, the key question that I've had here is relating to the managed schemes. So that is pool number 2 of the social health insurance that kicks in when you require a referral and you have obtained that referral. So the need to be in a social health insurance. Now, while I hear the issue of having a fully tax-based system, fully tax-based systems are ideally heavily inflationary, because they're supposed to be driven by VAT. And VAT, every time is added, it pushes out the price of all commodities compared to, if we were to go to a payroll-based system. Now, because we don't have a large number of people who are in the payroll system, then the VAT option would be the best option. However, it has huge negative welfare effects in the community, and also a community that is grappling with escalating prices of commodities as of now. So we then moved into a mixed approach, which is tax-based and contributory. The area system was largely contributory alone, targeting the payroll people. So this is a contributory mechanism targeting all Kenyans, payroll and non-payroll, but it's also targeting, to help the Kenyans by having the tax-based system, which will make sure that all Kenyans will access at least primary healthcare for level 2 and 3 in pushing services closer to the people. Now, it is not the role of the social health insurance to actually provide managed schemes. Managed schemes are an added advantage for the employed class. And that employed class is not all Kenyans. It's just less than 20% of the Kenyans who are employed. And in the old time, because they have been used to enhancing in the social health insurance, we have seen, contrary to what Dafji have highlighted, that we have managed schemes in the past have consumed more money than they have contributed. And that money they have been contributing usually comes from the national scheme, which is the scheme of all Kenyans. So then we separate the scheme of all Kenyans, where all Kenyans are treated equally regardless of your socioeconomic status, as well as your ability to earn, whether employed or non-employed, by having one social scheme which acts as the base insurer. Now, when you have a base insurer, which have a package that is defined and known, we have two issues that you need to highlight, that this is a tariff-based system. So therefore, if, for instance, you are, maternity care is costing 100,000 within, a public facility or a lower private facility, and for reasons that known to, the fact that you are advantaged to have an enhanced scheme, you go to a higher level facility that is, I don't want to mention names, that is charging maybe 300, for instance, then you'll have your social insurance as a base insurer take care of the 100,000 and not the bed as it has been happening with the current insurer, so that we don't have any middle class who goes to higher level facilities and does not claim, even when they have a complementary insurance. Remember, FKE went to court, and the challenge that was key was which is a base insurer, the social insurance or the private insurer. And the decision that they largely, were happy with was the fact that the base insurer should be the social insurance. That means you will first charge the social insurance before you charge any other insurance. And therefore, the managed schemes, the people who are employed by, a company that is private should go to their employer, which happens to be, the private firm, and they ask, how do you enhance our insurance? So they'll go to a private insurance and enhance. But as the benefit of the social insurance grows, you know that the need for enhancement will continue to reduce over time. And therefore, we see that also the people who are employed, like the people that Dafji is representing, it is not the social insurance that asked them to submit the money to them. It is their employer who withhold their money and submit it. So there is a window for the enhanced scheme to have more benefits by the employer, who happens to be public service, to actually enhance for them. And that is not a problem of the social health insurance, it's a problem of the employer. So the employer is supposed to deal with that issue, because majority of Kenyans have no other employer to go to. They are going to the government and themselves to be able to subsidize each other to afford care. So the product that we are talking about is a complete social health insurance product that is not interested in enhanced schemes that treat some people as special, which is, of course, the learning from, the colonial period of time, which brought those issues. Now, the last thing I just wanted to highlight is that when we get to the chronic illness, the emergency and chronic illness, emergency is for everyone, whether you have an insurance or not, just as the primary is happening, because accidents and emergencies are not choice variables. So you need to be stabilized before anybody could ask you for resources. And therefore, that was the thinking that drove to the realization that the emergency is for everyone. You don't need to have contributed, contrary to, and I would really beseech members of this team to actually read the bills and the draft regulations in detail. So the emergency is for everyone, and you will qualify. The same as primary healthcare is for everyone, and you qualify. You only need to register so that the system start knowing you. Remember, this is a completely digitized system. And that is where we want to, see savings of the healthcare cost that we have been incurring over time. And that will also assist the referral system, to have a professionally driven referral system where somebody is able to navigate through the system from the community level all the way to the referral facilities. So I want to pause there. Those are the few insights I would have wanted to give. Thank you.
Thank you so much, Dr. Mwai. And I think from where you have left it, I want to bring up, I want to pose the next point to Dr. Abdi. As you have had the description of how the benefits are expected to be delivered to beneficiaries across the different funds. A question or a comment was posed on administration of these claims now, as they will be, as patients will be seeking care across the different levels of care. So what do you have to add or to inform or educate us on how the envisaged claims management processing is expected to be done? You had there's a comment on part of it being outsourced, and I think I've seen a question on the chat, on the Q&A. So probably just highlight briefly on the claims management process envisaged as social health insurance will be implemented. Over to you, Dr. Abdi.
Thank you. Thank you also, Mwai, for the clarification. I think there's a lot of misunderstanding or not being able to have read and understood the four acts of Parliament, because sometimes people look at one without reading in line with the other. That's why we had this issue of why the primary healthcare fund is not input-based, without realizing that there's a FIF which is supposed to take care of the public facilities that have challenges. So before I come to the claims, there are a few things I wanted to highlight so that people understand why this new system is completely different, trying to cure some of the issues that we have had with the current NHIF. The current NHIF at one point was utilizing almost 45% of the money it collects on administration. So what's different from the new SHA? We have capped that in law, that the maximum allowed percentage of money that it collects is 5%. So 95% is supposed to remain for payment of services. So that means your administration cost has to be, or your administrative, the number of people that you need to provide these services have to be as few as possible. Number two, in this act, we said everything that SHA will do will be digital. From the beginning, registration to collection, to payment, to benefits, tariffs, everything that you are supposed to carry out must be done digitally. And there must be a footprint on how and where things are moving. So as you have looked at the current NHIF, the way it's structured is it's the one that empanels providers, and it was limited to facilities, hospitals. But the new SHA does not empanel, but it's also not limited to facilities only. So it can empanel, it can contract both individual and at the same time facilities. So there is a new aspect of that the new SHA can contract doctors, other clinicians directly. Empaneling has been left to the quality authority. In the Act, it says an authority, but the idea is to have a quality authority that does the empaneling. So the first thing we have done is removed that power from SHA, where it was doing everything from the beginning, which is empaneling, contracting, tariff setting, benefit packages, claim processing, claim payment, and dispute resolution. All that was done by NHIF as it is. So even from registration of members, collection of money, all that. So the first thing that we have removed is the empaneling part, where we have said this will be done by the quality authority. Then the new SHA will only contract you when you if you are acceptable or you accept the contract, that is the tariffs, as published. The second thing that we have done is that benefit package and tariff is being set by a committee which is outside SHA, but has representative from SHA that will be able to, based in a university, be able to look at what are the disease burden, what is the amount that we have collected, what are the things that we can provide. And that's why Mwai was saying that with time, we'll be able to optimize and put more resources scientifically to say, this is the challenge that we are facing as a country, and this is what we need. And this is what we are seeing continuously. And this is the kind of prevention mechanism that we need to put in place so that we don't exhaust the little resources that we have. That is also outside the SHA as it is. I know there has always been this fear because I remember very well when we said, we were trying to say, put the claims in different, almost 5 zones, but in the regulations now it's 8 zones. We were told not to prescribe those things, but we understand that the biggest challenge that will happen is when you have this kind of output financing, you need a lot of claim processing. And the claim processing starts from the primary healthcare fund to social health. So you have a huge number. And what are we looking at? We are looking at the issue of just clerical work, which is to look at through digitally, which with time will also be improved in terms of machine learning so that you don't depend on just the eyes of the individual, but you also have some sort of technology to verify those claims. So,
Dr. Abdi, I want to give you 1 more minute because I also want to give the other panelists some time. I have a number of questions which I also want to bring from the audience. So just 1 more minute, please.
Okay, I think maybe they will benefit from my explanation so that the questions they have might not be necessary. But let me continue. So the thing is, you want to now reduce your administrative cost at the SHA level, but at the same time, you also don't want to burden, but have a different entity to look at the claims and verify. But it's only SHA that pays. when the claim has been approved. So finally, when you look at how do you solve disputes? We have a tribunal. Previously, it was the branch level or at the headquarters level or at the board level that was the one that was telling you that you have made a mistake, and they are the ones who are telling you this is your judgment and it's final. So now we have a tribunal that will be able to solve disputes between providers and SHA, patients and SHA, and patients versus providers, so that you have an independent entity that will be able to look at what are the issues, what are the challenges, what are the disputes that need to be addressed. So when you look at in terms of structure, in terms of administrative, we have managed to reduce the burden on SHA, but we have also tried to delegate so that there are certain things that are done and they are done efficiently by someone else without burdening SHA as it is. That is the whole idea of the claim. The people who now imagine, because currently as it is, it's NHIF which is draconian, because they are the ones who decide everything from the beginning to the end. So when you have someone else doing just the part of verifying, just to look at, I think as a provider who does genuine claims, you will not be worried about who is looking at it, because you only want that kind of discussion to have with the person who is paying you, so that you have a discussion on how you want to share equally the fake claims that you want to submit. So it's better you have accountability and you have someone else to look at those claims.
All right.
Thank you very much.
Thank you very much, Dr. Abdi. And probably, W, just one comment that I probably want, and I come back to you, because I think there are some comments that have been made, and I'd want to also just hear from Dr. Deldesa, because he represents communities, he represents constituents, and just hearing from the technical perspective, from the operational thought behind the social health insurance. Dr. Jaldesa, how do you see this playing out at the community level, where you have people from different socioeconomic backgrounds? How do you see this implemented in various parts of the countries, from the semi-arid areas, from areas where you have stronger economic backgrounds, from the sparsely populated areas to the densely and more developed areas? How do you see this playing out in the country as if it's going to be rolled out? Over to you, Dr. Jaldesa.
Number one, the concept of primary health care actually emphasizes on people, the primary health care promoters, people who are looking after about 100 households and go visit homes. They have the basic equipment, blood pressure, and so that these ones can be referred to a dispensary, from dispensary to a health center. That's what primary care talks about. It doesn't matter whether you are living in the city or you are living in the rural areas, irrespective of which or the rural areas that people are living in. As I said earlier, the concept of universal health coverage is a noble idea. Implementation will be the elephant in the house. Mwai and others who are pushing for this thing from economic perspective will be able to assess and evaluate the value of these things that they're talking about 1 year after the implementation, because we have not yet started implementing the act as it is. Though it has been signed, I think there's the transition clause. We're still working with NHIF. what I'd said, and I'll repeat it, the main motivation factor is not actually healthcare to the people of Kenya. The main motivation factor is to do business with the authority. And that's why you want to reduce the staff at the authority and want to outsource the business component of claims management, meaning you want to give claims. Now, initially it was suggested 5, so that the country will be divided into 5 blocks. And now Abdi says there are 8, because those are things in the regulation, which is not in the act. So it's like they want to give the business aspect to 8 companies. And that way, though you are reducing the number of people there, the expenditure will be much more than if NHIF is doing its work, I think, as it is. But because the economics and the advisors felt that that business component needs to be outsourced, we agree with them. But the value of it, how it's going to be useful, time will tell. I think that's my position. If healthcare can be made available to the people of Kenya, irrespective of where they are and whether their socioeconomic standards, it's a good thing. Nobody will oppose it. But implementation, give it time.
All right, I like those comments that you've made, and probably over to you, Davji. I know you have a couple of comments as you've been ready to.
I may not agree with Dr. Jaldesa more, because it's always not at the goodness of the butcher that he sells meat, you know. It's very clear that when you're outsourcing 8 different companies, they must be getting money from that business. So it is really true that the Social Health Insurance Act is more business and vendor oriented than service provision. And I must just come back to what Abdi is saying, that everything will be digitalized from all extensions. I wonder how the digital system will get fatigue and strains if that is used rather than this aspect of outsourcing the claim component of it. Again, if you look at that particular act, I think Mwai said that the emergency care is for everybody, regardless of subscriptions. And I must say something here, that, you know, from the drafters of this particular act or the bill, whatever is in their mind and whatever is in the act is very different, because in this act, it's well outlined in section 26.5 that if you are not compliant to this particular act, then you cannot get services. You cannot access all these funds, be it primary healthcare fund, be it social health insurance fund, be it chronic emergency and critical care fund. So I do not know which part of the act says that if you have emergency services, that emergency need, you will access it without having paid the social health insurance fund. That's something that has to come very clearly. The other thing that is being sold out here, I think, is also part of the act, that yes, this is a baseline act. This act, then, it's supposed to cover every Kenyan. I must bring it out clearly that civil servants are Kenyans, and they offer services in the country. And the only difference between civil servants and other employees is that their employer is the government. So when the act says this is going to be a baseline, yet the contribution that are mandated for them to pay as premiums is 10 times what they were paying before. And I'm speaking in this context for doctors, for example. If you are paying 1,700 in the National Hospital Insurance Fund, you are going to pay 14,000 plus the medical allowance that you relinquished. Then somebody tells you that this is a basic or it's a baseline care that you're going to have. On top of that, I must bring it out clearly that if it's a policy that is being made to replace National Hospital Insurance Fund that was having provision for comprehensive cover, you cannot tell us that let's go talk to our employers, yet our employer is the one who has sponsored the bill. That is the point where we don't understand what the Ministry of Health really mean when they're actually in charge of making policy that govern service provisions even in the counties. That's the point of our departure, because you can't create for us a problem and then tell us, go talk to our employers when you are the employer. So it means that at the onset of this act, the 6 million families who then will have to look for monies to pay for the service provisions. It means that the out-of-pocket expenditure, as it is, because of the baseline nature of the Social Health Insurance Act, many of these individuals will then now to see whether they need to sell their lands or whether they need to put more mchangos. That's what we were repudiating very strongly. The other thing that I must agree also with Mheshimiwa very strongly is that when you talk about primary healthcare, yes, we have primary healthcare promoters who we know have no medical knowledge, because the people that are just picked within the community, maybe because they are known to the community or they're famous in the community, and then they've been equipped with this to do a level 1 services within the dispensary level. These will work in a very functional, or in a society where healthcare is highly functional. So when this is only looked at primary community health promoters, if they go sensitize you and see that you need to go to level 2, level 3, level 4, which hospitals will you go to if you are not able to pay? Or if you can't afford to pay? Because that's, again, to access these funds, you must be able to contribute. That's why ideally in the discussion of these funds, and the way I've said earlier, and I'm happy that Dr. Jaldesa has repeated really what I've said earlier, that this thing is more vendor-driven. It ought to look into it ought to have bettered what is in NHIF in terms of giving the cover. Ideally, we were expecting, from what Abdi had said earlier, that every Kenyan then will have an enhanced cover once you pay the 200,000 for the social health insurance fund. So that everybody, you will go to any level 1, any faith-based, private or public hospital, regardless of whatever you're doing, that will be okay. But this aspect of just saying you will be able to access baseline care and then you can go talk to an employer to get you the private insurance is immoral.
Thanks for those comments, Davji. And I also want to hear from Anita on her points on the discussion as it's moving along. Over to you, Dr. Musiega.
Thanks very much, Dr. Obita. So I just wanted to raise some issues, especially to Dr. Mwai, on the issue on the administration costs are capped at 5%. And just to point out that it is one thing to cap the administration, and it is one thing to implement the SHI in such a way that you are actually limiting the administration costs. Because even when we say we have digitized the system, I mean, this government has a lot of experience on digitizing systems. And does it really translate to actual improved benefits, or does it then just become another barrier? For example, one of the systems that the government has digitized before is the procurement system. Has it really translated to improved outcomes on the procurement process in such a way that we're actually limiting misappropriation across the years? So the fact that we say that we have capped does not really mean that at implementation, then we will then cap administration costs. And the way the system is structured in such a way that in some informal sector have to contribute, it means that we as a system, we have to put a lot of money in terms of getting these people to actually contribute. But another thing is that there's an increased focus on PHC, but even from how the government has structured the contributions, more money is actually going to hospitals than to the primary healthcare, because the contributory aspect of it is almost targeting to raise 5 times what is going to PHC. So, I mean, there's still an opportunity to improve financing to the primary healthcare. And I still insist that there's a lot of opportunity to learn from other countries, for example, Ghana and Rwanda. And even in those countries where SHI has actually, like in Ghana, for example, they've taken 20 years to get to 70% coverage. And even when they're at 70% insurance coverage, only 10% of their total health expenditure actually goes through the SHI or comes from the SHI, their social health insurance. So the main goal for us should then be, are we actually ensuring that there is financial risk protection? Because access to the fact that you're covered by an insurance that does not entirely translate to financial risk protection. So it's important. And then there are also issues on fragmentation. While the government is actually addressing an important issue that we need to have access to emergency care, we need to have access to chronic care, and then we say that there'll be a clear line. So actually implementing this clear line on what is emergency and chronic versus what is SHI versus what is PHC will actually add to the administrative costs. And this is an actually genuine problem that needs to be solved, but all of this also adds up to what exactly are we facing as a country, and what are we targeting to achieve, and are we really achieving that? And there'll be a lot of wins, of course, in terms of the universality. A big win for this is the fact that the government is trying to reach everyone. So the universality aspect is a very big win for us, but the question is, can the government actually reach to the informal sector, and at what cost? And the separation of functions, as previously outlined, that is a very big win for us, which we've been struggling with NHIF. So for me, I'll say we need to find a way to optimize the wins that the government is currently, especially the universality aspects and the separation of functions. But we also need to find a way of learning from other sectors. For example, when we say primary healthcare will be funded through fee-for-service, yet we have evidence that even from NHIF, that capitation is actually the best worldwide provider payment mechanism at the primary healthcare level. So I think we need to learn from other regions, from Ghana, from Rwanda, optimize what we are doing right, and also try and improve on what we are not really doing well. Thank you. Over.
Thank you, Anita, for those additional comments. I see we are at the top of the hour, but I see Dr. Jaldesa's hand up. Professor Jaldesa, over to you to make some last points as we begin to wind up this webinar. Over to you, Prof.
I just want to comment on this business of digitalization. I've seen in other countries where somebody has a digital card and they'll present it to any health facility within the country, and they'll seek treatment and be given treatment. That is the purpose of the digitalization, so that if you're in Mandera and you come to Nairobi and you go to Kisumu and you feel unwell, and you can go to a health facility and will be attended to. That is the purpose. Our team seems to be emphasizing on money collections or payment of money. But the purpose of digitalization is that the entire country is somehow connected, that your card, when you present it, somebody will just put on the computer and it gives you all the details about this individual, and including a history of medical history. And you'll be looked after without being asked a lot of questions. And that is the idea of the digitalization, not on whether to manage claims. I think that is the point I wanted people to understand, so that what do we want? We want the digitalization, but that digitalization is supposed to help us, that if I come from Mandera and I go to Kenyatta National Hospital, and just because I'm in Nairobi, I'll be able to go and get services. That is it. Is that what Abdi is promising us? And then the other component of which has been happening with our act, unfortunately, we were involved in the passage of the act, is that it is heavily inclined towards private practitioners. It kinds of pushes away people in the public sector, that it gives priority to people from the Juakali sector, from private hospitals. But where are the practitioners? I know the Director General is there on the board. A representative of KMA is there. But even that KMA, it has been silently pushed to include not the traditional KMA system, but so long as that person is not working with the government. So there are a few things that we need to streamline as the time goes by.
Thanks for that, Prof. And I want to just come back to Dr. Mwai very quickly before I give the panelists some closing remarks, because we are just top of the hour. So just bear with me, participants of this webinar, for the next couple of minutes. Dr. Mwai, probably just some quick fire on some of the questions on the chat I see have not been responded to, so that I can also give you an opportunity to respond to the other comments in the discussions. So there's one question that has been posed: what is the government financial contribution to the fund? Secondly, when will the SHI be implemented? I think this one is back in court. Probably the question here: does someone registering for the first time now register for NHIF or for SHI? I know that is in the Act, but you can give that answer directly. So the social health insurance is how much? Or they will carry the former 500 universal contribution? I think this is a question touching on the regulations being made. Probably just start off from those, just very quickly, without going into finer details, so at least we can give the participants a sense of what's also going on in the background. So over to you, Dr. Mwai.
Thank you very much, Chair. I took some time I had led some other questions that had been in the chat, but I want to first begin by telling our MP Professor that the digitization process that is envisioned within the Social Health Care Authority is an end-to-end digitization, and therefore you will not need to carry cards going around, and be rest assured that that is already covered along. On the issue of 5% administration cost, I think we have, over the years, when spent a lot of time in benchmarking as a country, going around and learning from the countries that have done well in the UHC domain, as well as universal healthcare coverage. And here we talk about the countries like the Thailand system. The Korean system is also looking good. We have the systems that are, working within the Japan system, as well as the Israel system. If we look at those systems, and what they have been able to do is to be able to administer social insurance at very little cost. And while we are talking about capping at 5%, which is in line with our laws, it's also important to note that at some point, the NHIF administered cost was at 40%, dropped to somewhere in the range of 15%. Now it is somewhere in the range of 11%. So it is good to have those statistics that are out there for us to know that 5% is not little resources, but it is what best practices are showing. Actually, is less than 5%. The desire is not 5. 5 is still high. The best practices are in the range of 2 and 3% in terms of use of money. Because when money is absorbed for administration, that money is not available to pay for healthcare bills when the people who contributed it get sick. And that is a big problem. The other issue that is important is that what have been asked is relating to fragmentation of pools. And I want to say that the current NHIF has above 96 fragmented pools. Some of those pools are the pools that are enhanced schemes. The government itself is in charge of fragmenting the NHIF at a tune of above 34 pools out of the 96 pools. So this is where we have special people inside Kenya, social health insurance. Now, if fairness is something to go by, then we cannot have special people inside the pool. And contrary to expectation is that they may be enhancing the national scheme. They don't enhance it. They eat from it when we look at the benefit packages that have been offered to those teams. So the idea that is important is to have a good benefit package that is available to all Kenyans, regardless of whether you are employed or non-employed. But more importantly, is that that benefit package is known and outlined. That is why this benefit is being included as part of the schedule within the social health insurance regulations, so that everybody knows what they are entitled for, and therefore it's not a black box in there. And if you are lucky, and I want to tell Dr. Davji that enhancement will always be there, because when you even give the highest level of comprehensive package, there are people who want to go outside the country. There are people who want to be in hospitals where they are staying in a 5-star kind of treatment. And those things cannot be treated within a public healthcare system, because the financing of a public healthcare system is reaching a good depth in terms of provision of services, but doesn't mean that it will be the highest in terms of other non-medical services that ideally would also be interested with people. So if you want to go to 5-star in a hospital, then if you have an enhancement, you are better off. So let's not envision a time when nobody will be enhancing, because that is an infinite, kind of search that we might be involving ourselves with. The other issue that was raised that is important is the issue of payment for fee for service. And I want to highlight that the prepayment mechanism, the provider payment mechanisms that are available within countries, we know very well that capitation is an option that is there. But we can have banded capitation that ideally works almost close to fee for service. And that makes sure that you don't claim for money for services you have not provided. There's no need of a facility to say that my catchment area is 10,000 people, and you are given money for 10,000 people, whether they get sick or not, because that gives you an incentive not to want to treat people when you receive the money. Because the more you don't treat them and you don't provide services to them, the more profit you make. And therefore, the Kenyan masses, and more so those who can't afford, are left in the masses of gods, because the providers would ideally do not want to provide services, because already they have been paid for the population they have been capitated for. So we must get a way of making sure that you are given a capitation, but if that capitation is banded, then it becomes a fee for service, and therefore it's an output-based financing mechanism that is important. I want to end by highlighting two things. One is that let us also look at this country and value the people who have not gotten the latitude of being employed. And in this case, I want to highlight that this country is largely 80% of people are non-employed. And in those non-employed 80, if they want to be carried by the employed people, then we'd need each household to carry between 4 and 5 other households for them to be able to contribute for them. That is impossible. Now, because of that impossibility then, and we then need a system where everybody is a member of and contributing to and accessing benefit the same. I want to highlight to this team this evening that for the people who are poor now, not poor even, I would say anybody who is who have an income of 10,000, the contribution to the current NHIF is at 5%. 5. So they pay 5% of their income to NHIF for health. If you are earning around 49,000 or so, you will be contributing, your rate will have dropped from 5 progressively to get to around 2.66% around the time you are getting to 50,000. Now that will drop to the fact that by the time you are earning 100,000, your contribution is at 1.77. Now, by the time you are getting to 1 million, your contribution is around 0.0 something percent there. Now, if we are talking about a fair system, as people have highlighted here, then the fair system can either be proportional or it can be progressive. The progressive is when instead of the way the one with 10,000 was paying 5%, then we have the one with 1 million paying 5%. But we know that the community, the individual utility function is always above the society utility function. So nobody wants to subsidize the other. Then the only middle ground is a proportional fee that everybody pays regardless of whether you are employed or not, regardless of your income, whether it is high or low. And therefore, the discussion of a proportion, and I'm saying a proportion because the 2.75 is out there, of the individual income, then make sure that nobody is advantaged or disadvantaged because you are paying based on ability to pay. So it gets the one who has been paying 5% all the way to those who have been paying 3, the ones who have been paying 4, and the ones who have been paying 2.8, all of them come down. And I want to highlight to you this evening that the majority of Kenyans are there. So there is 1.4 million people whose contribution, who are employed and whose contribution will drop. So as we have this discussion, let's be a little bit more objective on the issue of fairness, equity, and also interrogate as scholars and the experts in provision of care, interrogate the benefit of package to find whether it is comprehensive enough in a way that you may not need to enhance it as a Kenyan, regardless of whether you are employed or not. But if you are lucky to be employed and your employer is, feeling like they want to make sure that you get, that 5-star, 4-star kind of treatment in facilities, then if they enhance for you, you should give thanks to the Lord because you have an employer. Now, the issue of the capping is important, and I think that it's the last thing I would highlight. The issue of capping. The regulations are out there, they are being discussed, and Kenyans are giving their views. But I want to highlight 2 things. One is that when capping is mentioned, the issue of equity and fairness goes out because you cannot have capping and equity in contribution in the same sentence. When you introduce 2.75, for instance, and you cap, you advantage the poor. Sorry, you advantage the rich because they will pay less proportionately compared to those who do not have. So it's a delicate balance, but I understand from health economics principles why capping is important. And therefore, that is why these discussions and engagement are very, very important. Lastly, is that this is a system that is not designed to take money off the public system. But it is a system that is designed to appreciate that when market failure occurred, when government was unable to treat its people, the private sector also emerged. And therefore, we cannot bury our heads in the sand and assume that all Kenyans will go to public facilities when we know that almost 44% of Kenyans are going to seek care in private facilities. And that is why we are saying, let's say we have fairness. Fairness in the ability of people to access care and have a choice to make between the public, the private, and the FBO. But contrary to what has been happening in the past, where NHIF has been paying more to private, even for the same services, compared to public, the facilities should receive the same amount for the service they have provided. And then to cushion the public facilities, we provide the FIF system so that now our doctors who are running in public facilities have monies they can command, make decision on, and guide on what's the best way to put that money to improve services in their own facilities. And this is a luxury that is not available now. And this is actually something crucial that we lost after devolution. And therefore, I would really beseech the members to really look at the spirit that is in the regulation. The last one is that currently we have 50 billion that people are paying directly as out of pocket into our healthcare system. getting a disease is not a choice variable, and therefore nobody chooses to get sick so that they pay. In this relationship, then what we are trying to do is to convert some of those prepayment monies into a social scheme so that people are able to be prepared before they actually get sick. So I think in all fairness, I would think that we are trying to separate functions in NHIF to make sure that in the social insurance to make sure that we separate functions and improve efficiency. Another important thing that we need to learn is that as we move on with our digital system, we'll go to machine learning and all these things continually moving human interface. And if you look at the Thailand system, this is how they have been able to save a lot of money and cover for healthcare without having to, utilize too much resources in the long way. Thank you.
Thank you very much for those additional clarifications, Dr. Mwai. And I think in the spirit of what I hear from everyone wants us everyone is speaking in the voice of they want to get more health for the resources that we have and increase access, and not just access, but quality access of care across the entire nation. So with that, I will probably give everyone just a 30-second closing remark so that I can also close this discussion. We have run over time. So I will start with Anita with her closing remarks. So over to you, Anita, 30 seconds, punchline, and give us some juice from what you have just said and discussed.
Thanks, Walter. Thanks, Dr. Wai, and all the other panelists for the insightful remarks.
You seem to
I think for me, for some of the aspects, were many steps in the right direction. Like I will emphasize the fact that we are seeking to. Oh, sorry. Yes, can you hear me better now?
Yes, it was getting better now. Just carry on.
Can you hear me better now?
Yes.
Okay, thanks. So I was saying thanks to all the panelists, and in my opinion, we are in some of the aspects, several steps in the right direction, but in other aspects, unfortunately, several steps in the wrong direction. There's a lot of opportunity to enhance what we are doing right in terms of reaching everyone and ensuring that everyone is under this cover. And I will just re-emphasize that for most of the countries that have made progress, it's because the SHI is majorly temporary. So that's very key for SHI, for making progress towards SHI. And of course, the separation of powers that NHIF previously had, that is a very right step in the right direction. However, in terms of contributory mechanisms and to primary healthcare versus what goes to the higher levels of care, we have a lot of progress, but definitely looking forward to a government that is able to learn from other countries, learn from NHIF, and learn from people's perspectives. Thank you.
Excellent. Thank you very much, Anita Musiega. I'll move on to you, Dr. Abdi, and 30 seconds of your closing remarks and what insights or parting shots you want to give all the members of this webinar.
Thank you. Two things. I understand Davji has a constituency and there are people he represents, but he also needs to understand that there's a way he can represent them without pushing out the agenda and the universal coverage for the public, because this cover or this SHI is meant for everyone. It doesn't discriminate based on age, based on disease, based on employment. So it's universal. That's one thing that he needs to understand. Yes, it's government that has introduced, but he also knows that government has different departments. So he needs to go to his employer and have that discussion on how to enhance what civil servants, mostly the doctors he represents, how they should get the enhancement that they need. So it's not tied to this. But if this helps improve equity for everyone, I would take this universal rather than having a few people benefiting more than the others. The system he is advocating for, which is the enhanced scheme, and saying that this vendor-driven, private, all that, you need to remember that currently the hospitals that benefit from enhanced scheme are private sector. Starting from all the doctors seek their services from the private sector. So you cannot be speaking from one side of your mouth and at the same time speaking from the other side. So you can't say this social health is going to benefit, and at the same time you're advocating for a system where the beneficiaries only seek those services mainly from the private sector. So that's double speak, and it's not fair. If you look at the way this has been designed, it's open for the normal Kenyans also to have the same luxury that now currently the enhanced scheme people have, that they are able to choose where to go. That choice is also being given to the common man. And I don't understand why that's a problem when it's given to the common man to choose also where they want to seek services. But more importantly, as we said, the FIF has come in, and I'm hopeful that the counties will have proper managers of those health facilities who will be able to improve the service delivery for everyone. Because I believe that you don't know when you will need that service, when you will fall sick, or when you will be involved in an accident. So in my world, I am happy when everyone and every facility is up to par, and there is financial protection for every Kenyan, not just for a few individuals, but we have universality, that we are all equal when it comes to health service or healthcare, the kind of healthcare services that we receive. Finally, we are in agreement that it's not easy, and no one has said that it's a walk in the park. It's a very big task and a big challenge ahead to get the 80% to come on board and contribute regularly without dropping, so that you remove the part of adverse selection. So my expectation actually is that we will get pointers or people will give us ideas on how to implement and how to push that this becomes a reality. That is if we are all interested in a UHC. Because if we are interested in UHC, this is our best shot. So it's to look at and say, how do we help in terms of getting this 80%, or how do we educate the general public that you need to contribute, you need out of pocket is not sustainable. And the only way to do these things is when everyone contributes something. The Harambee spirit that we talk about, Because as we speak now, every one of us is in a Harambe somewhere, contributing to someone else's hospital bill. But that's now what we need to tell the public, that instead of having those small WhatsApp groups contributing money to individual people, we rather have this one big basket where everyone is paying something. And I don't see why paying for car insurance is acceptable, but paying for a health insurance becomes a problem, because we seem to prioritize our cars than our bodies. So for me, I would say let's give a chance to this new, which Professor Jaldesa kept on saying, yes, it's not a new idea, but this is the first time we are trying to implement UHC, and everyone else, all other countries have tried. Some have failed, some have succeeded. So there's no one particular financing mechanism that is the best in the world. Every financing mechanism has its own challenges, but this SHA is the fairest, in my opinion. Thank you very much.
Thank you very much, Dr. Abdi. And probably I'll also ask Prof to give us his 30 minutes closing remarks. Do I still see him, or he has dropped off? Yes, I see he may have dropped off. So Davji, I beseech you for 30 seconds so that we can
although you must realize that I'm the only person who's read a draft of this bill. The rest are draft of it, and therefore whatever they're giving is different from what is written. But I must just say that I did not know that Abdi and Mwai are politicians, because from whatever they're saying, it's categorically brings it out as clear, well-should political leaders. But I want to remind Abdi that civil servants, and doctors included, are not private citizens of this country. They're parts of the public that ought to be covered. And also, paradoxically, I want to tell Mwai that it is quite funny that the drafters of these acts, the government, state officers, all have very hefty insurances. That they're the ones that visit those level 5-star and 7-star hospitals across the world. But we are saying here then that this is equal for all. This aspect of equity, this aspect of UHC, this universality. I mean, I believe that from what you guys are saying is bring a new definition to those particular terminologies. Because in reality, if we are to look at the universal healthcare access, let me just give you a practical model of Australia. It is for every person, be it a minister, be it a president, be it everybody, that whatever the government has put aside and set forth is for all of you. If you want to get any extra, therefore you have to cut it from your pocket. But here we have the government that in this next year, when in case we don't win, these cases are in court, will be spending 150 or 142 billion private insurance company to cover both the public employees and the state officers. And this is the reality. We are going to end up with a situation that teachers are in now, that police are in now, where they are directed to facilities that they go to, and they can't access the same care, despite the billions of funds that have been put to those particular insurance companies. Therefore, if we are really out to have universal health care, the government, first of all, put the 140 to 150 billion that they use on private insurance to share. Then let's all be there for care, rather than saying that it is for everybody when that's not the case. And again, I must say, there's a very big aspect of impediment for care to the people who are in informal sector. And here, we don't just say informal sector. Anybody who is not salaried, what will happen to them? You are supposed to pay your subscriptions annually. So let me give you a practical example. If a doctor, for example, works in a particular institution where he's alone and is making 1 million a year, he is to pay tax of that 5%. That is 350,000. Is to pay housing levy of about 1.5. That's 15,000. He's again to pay the SHA what 2.75, that's about 27,500. That is 400,000 you pay out of that 1 million. Then you are told to go and procure a private insurance to cover you to seek care. That is the insane part of all these things. So it is reality that as we need to be more realistic than theoretical in what we are trying to put forward and in the way that this is going to help us access care. If you do away with the comprehensiveness that is going to serve 6 million, tell me if those people will not wallow in despair in seeking care, where they're not going to be, whether they're not part of the people that actually in the public who need to get this care. That is where we are seeing the problem. And I must remind all of us, lastly, that those who are in court, who have read this act, because these are the drafters, they have their biased thought and biased presentation of the case. We have Kenya Union of Commercial and Allied Workers. We have Kenya National Human Rights Commission. We have Katiba Institutes. We have People's Health Movements. We have the Institute of Social Accountability. We have Civil Servants Union. We have KMPDU. These are institutions that are in court against this. After reading them and realizing the impediment that are going to cause, the suffering and the despair that will cause. I know that some other individuals also who have filed the cases, but basically this is coming out as people see. You look at yourself, how are you going to seek the care? So it's a time that we should not say that there are poor people. We should fragment people into classes. Let's be ourselves as Kenyans, both the public, ourselves. Will this care be able to work for you? Thank you.
Thank you very much for your final comments and the punchline, I must say, Dr. Davji. I think final comments to Dr. Mwai as we close. It is now 9 p.m. There are people who need to also attend to their social responsibilities. So closing remarks, Dr. Mwai. I hope you'll make it to the 30-second mark. As no one else has managed to.
I will try, but I'll begin by highlighting that let us be agents that can dream of a better future, but let us not confuse ourselves with the hallucination, because one is achievable, the other one is not. The second thing, so let us be able to know that as a country, we are not a rich nation, as we may want us to think. We are a country that has huge problems, and therefore we cannot have a healthcare system that is fully taxed, financed, and that is why the mixed model would serve Kenya better. And I want to again highlight Ghana, who have already defaulted on its debt obligations, is crawling back with its inability to finance their healthcare system within a fully tax-based system, because our economic indicators cannot allow. Rwanda, on the other hand, is also coming back to reaggregate its community healthcare systems, which have not been working effectively at that level, to come to a social health insurance for the whole country, and that is where they are going. So we learn from those two countries that are of African descent, and we also see their mistakes, and not to perform them is the best thing that we can do. I also want to highlight that when we finish being employed and we finish working, we will be Kenyans, common Kenyans. And therefore, when we look at the social health insurance, we look at enhancing the benefits of all Kenyans. And in that enhancement, then we are saying that that enhancement is available for the employed, the non-employed, the people Davji is representing, the people who have gone to court, the makangas of this town, as well as, those unionizable and those that are non-unionizable. We look at the benefit package enhancement that makes them, as Kenyans, be able to access services. If you are lucky to have your employer who have deducted your own money, by the way, you can claim that money and tell the employer to give you, as they used to do, and you don't enhance, you come and enjoy services of a social insurance that is robust for all Kenyans. So enhancement is a preview of some few people who are employed, and they have always sat on the table to make sure they make decisions on how to optimize their benefits, and they don't remember those who are not employed, those who have no scheme, those who cannot access services. So those those that really, they don't care the type. Now, what we are saying is that we are bringing an equalizer, which is a social health insurance, which we should all work. I'll be happy if the team that is employed is challenging the size of the benefit that is being provided. That is progressive. But every time we move towards, segregating the country and having the social insurance that is for those who have and the benefit of those who do not have. Those who are employed have better monies, they are enhanced, and they can access better care. Those who are not, then they are in the national scheme. We need to have a national scheme for all of us. So that the way I am seeing devotion in DAFG talking about those people who are employed, I want to see that devotions talking about the benefit package for all Kenyans, including his employed people, because they are Kenyans first before they get employed. Thank you very much.
Thank you very much, Dr. Mwai. And I want to call this webinar to a close. I really want to thank all the panelists. I think you have given quite a lot of insightful information and discussion around this. As Dr. Mwai, you have mentioned, as you are closing on the benefit, I think probably, hopefully, by the time we have our next webinar next year, the draft benefit package would have also come out, and I think people can be able to ventilate and discuss around it.
Peter, I think you can remind guys that there is an order, conservative order, actually, that is currently in force, where up to, I think, 7th of February, meaning that even the acts are not implementable, are not in force, unless otherwise the court decides. But that's the status we are in now.
Yes, Dr. Davji. And that's why when I started off this webinar, I actually gave a small background as to when the act was enacted on the 20th of October, when the Ministry of Health operationalized through a Gazette notice on the 22nd of November, 2023. And then there was the High Court ruling by Justice Chacha suspending the planned implementation of the Act. And I was also very clear to mention that whatever we are discussing today should not appear as prejudicial. And it is just to inform the people that on what has been presented in the draft, what the spirit of the Act is, and what the challenges different actors are seeing from the draft as it is, and probably what we should look forward to if you notice my words were if and not necessarily when this is implemented. So I believe just from this objective of this discussion, we were not necessarily having prejudicial discussions, and we're not discussing what is in court. I think I also want to leave it at that and not bring up whatever is in court. I think what we are discussing is what is in the public domain and up for debate. So with that, allow me to close this discussion. Thank you very much, ladies and gentlemen. As I close,
just one thing.
Dr. Abby, just allow me to just finish. As we close, I just want to also mention that next year, KMA is having its annual conference, and probably this is a good point where, Brenda, you can put up the poster. So this is just to also let you know, in the event that you also would have any papers that you want to present, or any presentations you'd want to have at the Kenya Medical Association conference, this would be information for you to plan accordingly in advance. With that, ladies and gentlemen, have a good night. Happy holidays. And if I don't get to see you before the close of 2023, I hope I see you in 2024. Merry Christmas, Happy New Year, and happy holidays. Thank you very much.